welcome. What a better way to spend, or there is no better way, sorry, to spend your Monday morning than chatting with the three wonderful hosts and panel speakers that we have today. So today, what we're going to talk about is that one of the biggest challenges that we have to face in the coming year or two. So last year was a horrific year for the system and healthcare. On the 6th of July in 2021, the Health and Care Bill was published, setting out the legislative proposals, that's a difficult word to say on a Monday morning, legislative proposals to reform the delivery and organisation of healthcare services in England, promoting more joined-up services and to ensure more of a focus on improving health rather than providing healthcare services. So that's stuff that we've been talking about for ages around wider determinants and beyond. The legislation aims to avoid a one-size-fits-all approach, enabling flexibility for local areas to determine the best system arrangements for them. And this will then be further supported by other measures, including improvements in data sharing and enshrining the AAA for NHS organisations to better support health and well-being for everyone. Better quality of health and services for all, sustainable uses of NHS resources. So ICSs and the system have this huge challenge, or is it an opportunity, to better allocate resources to address the wider determinants of health, to improve health rather than providing healthcare services, and of course, very, very importantly, addressing inequalities. So what approaches can they take to better understand the care pathways and how efficiently are their pathways being run today? And can they better allocate resources? And there are three people who can help you better understand that today. And so we have three amazing speakers for you. So first of all, Deborah O'Callaghan, who works at NICE and is the Assistant Director for the Midlands region and has a wonderful talk to you today about technical efficiency, and the tools that they use. And there's an amazing new tool that Deborah is going to give you a sneak peek of, or at least describe of how they can address inequality. Next, we have Prof. Gwyn Bevan. And so for all of those who think that I'm terrible at economics, you can blame Gwyn because he taught me for my master's. So Gwyn, who will talk to you in detail about allocative efficiency and one of the tools, again, that will be publicly and freely available that you can use today. And then finally, we have Peter Spilsbury, Director of the Strategy Unit. And I think I'm legally obliged to say the most handsome Peter Spilsbury you'll ever meet, because he happens to be my boss. But Peter Spilsbury will talk to you about how you take this insight from Deborah and Gwyn and how you share with you a real life example of how it works. And then there will be a panel. And on that panel, we'll be discussing how technical and allocative efficiency can address inequalities, how it can help us resource for restoration planning and elective care. But of course, we desperately need your questions too. So please use the chat to record your questions as you're going through, and Gwyn, Deborah and Peter will be there. We do have one surprise panel member for you, Wayne Smith, PhD in economics, the head of economics at the Health Economics Unit, who will be joining that panel too. So just to say, a great day I'm talking about efficiency and value, but of course the key bit around our session is how you take that insight into action. So thank you very much. I will now pass over to Deborah for her talk.
Thanks, Andy, and thanks for inviting me to join you. There's about to be a slick handover of slides now. Let's see if I manage to pull it off. Okay, can everybody see my slides all right? Yeah, great. Okay, I'm just going to minimize you. There we are. Okay, so thank you for inviting me to join you today. I have to confess, I've got a cold, so I might start coughing and spluttering, and I've also got a get out of jail free card if I'm not able to hang around for the panel, but hopefully I'll be all right, and LEMSIP will live up to its name. I don't think we've evaluated it at NICE, but I'm sure it'd be cost effective today. So my name is Deborah O'Callaghan. I'm the Associate Director responsible for the Midlands and East region at NICE. But I'm also leading, I'm the public health sector lead, and I'm leading our work around health inequalities. I'm not a health economist, so hopefully this will be quite a nice different perspective this morning. But I will be talking about our approach to considering cost and clinical effectiveness and the sort of technical efficiency approach. So you're going to hear a health inequalities person who's not a health economist talking about health I can't even say it, health economics. There we are, it's a good start, isn't it? Well, thank you for joining me. So I'm going to talk briefly about NICE, who we are and what we do, so our purpose and principles and our products, and then our approach to assessing clinical and cost effectiveness. And then also the work that we're doing to strengthen our approach to considering health inequalities in the work that we do. And as Andy mentioned, this includes some work we're doing with the University of York around developing a prototype health inequalities calculator. So the core purpose of NICE is to improve health and well-being by putting science and evidence at the heart of health and care decision making. So it's obviously a key theme for today. We develop guidance and quality standards, as you'll know, and you'll all be familiar with them. We use NICE guidance and standards to understand what good care looks like. So when we develop NICE guidance, we consider both effectiveness and cost effectiveness, and then we develop these sets of recommendations. And the intention is that they inform professional judgment and discussion with patient service users or carers, and they can provide assurance that services are being provided safely and effectively, and that resources are being used wisely. There are 13 principles that underpin our work, and a commitment to reducing health inequalities is a long-standing focus, and it's threaded throughout these principles. So, for example, Principle 1, which is about producing guidance and standards that reflect national priorities, part of our topic prioritisation process includes consideration of the potential to reduce health inequalities. Principle 4, which is about considering the advice and experience of a wide range of people. We have a public involvement programme to support people who use services and their families and carers and the public to take part in our guidance development work. And the public involvement programme promotes their involvement regardless of disability, language and other potential barriers. So we have a real co-production approach to public engagement. And Principle 9, so aim to reduce health inequalities, it speaks for itself, but our guidance should support strategies that improve population health as a whole, while offering particular benefit to the most disadvantaged. And in addition to considering the protected characteristics, we also take into account inequalities arising from socioeconomic factors and circumstances of certain groups of people, such as looked after children and people who are homeless, for example. So our guidance aims to reduce and not increase identified health inequalities. So obviously our evaluation processes need to enable that sort of balanced consideration to take place. Sometimes we might need to make recommendations for a particular group of people. So Principle 10 is about considering if it's appropriate to make different recommendations for different groups of people. So while our guidance aims to serve the interests of the population as a whole, sometimes the available evidence shows that there are differences in effectiveness in different groups of people, and also differences in cost effectiveness of an intervention for a particular group of people. So sometimes we need to make different recommendations accordingly. However, today I'm going to be focusing predominantly on Principle 7, which is about making recommendations based on an assessment of population benefits and value. So when NICE was established, it's about 21 years ago now, the Secretary of State for Health made it clear that we should take into account both the costs and benefits of interventions in our recommendation and encourage the effective use of resources. And this was then restated in the Health and Social Care Act in 2012, and also the NHS Constitution commitment to provide the best value for taxpayers' money and the most effective, fair and sustainable use of finite resources. So NICE recommendations should not be based on evidence of costs and benefits alone, however. We also recognise that decisions about a person's care are often sensitive to their preferences. We support personalised care and shared decision making. And I've shared a link with Matt, he might post it soon, for a shared decision making guideline that we published in June. And the shared decision making guideline is very much there to support practitioners with informed conversations with people to ensure that they understand what their desired outcomes are and that important decisions are made in collaboration with patients and service users. So what is considered in guidance development? Well, the committee have a number of factors to weigh up and they need to balance them when they present the evidence. So these include effectiveness of the intervention and cost effectiveness, and also the extent of uncertainty and social values, as well as practicalities of implementation. Patient voice is an important element when we develop guidance. For example, when we developed a guidance on psoriasis, the clinical research told us that the amount of psoriasis is what most affected people's quality of life. However, patients told us that the location of the flare-up, for example, the face or the joints, was more significant. Now, this is where it's going to get fun. So the different types of economic evaluation, as explained by someone who is not a health economist. Cost effectiveness is often used as a general term for any analysis where a non-monetary measure or health gain. So we have cost impact analysis. Now this assumes that both interventions provide equal benefits. So it's only costs that are being compared. So the cheapest intervention is therefore the best value for money. It's not a true economic evaluation. In cost effectiveness analysis, the benefits of the intervention are measured in natural units, for example, blood pressure or weight loss. As this involves exploring more one domain of benefit at a time, for example, weight loss, it requires a decision to be made on which single outcome best represents the intervention. In cost utility analysis, the benefits of the intervention are measured in healthy years, so quality of life as well as quantity of life. As this involves measuring healthy years, this is expressed as a number between 0, which is death, and 1, which is perfect health. And therefore you have a gradient in between. So 0.75 is good life, but not perfect health. So the most commonly used measure of benefit and cost utility analysis is the QALY, the quality adjusted life year, and I'll be mentioning that a lot throughout this presentation. But there are other measures, for example, DALYs, or the disability adjusted life year, and also healthy year equivalents. Cost benefit analysis is when you consider the benefits of the intervention and they're measured in monetary units. So the decision to fund a particular intervention is therefore decided by whether the benefits of the programme are greater than the costs. This type of economic evaluation, it's not often used in healthcare because it's difficult to express health benefits directly in monetary terms. So it's cost utility analysis, the one using QALYs that we tend to use at NICE. But sometimes it's difficult to estimate QALYs, so sometimes we do use cost effectiveness analysis instead. So what health outcomes are important? Well, outcome measurement is important when establishing whether a new intervention is more effective than an existing one. And there's a lot of ways to do this. And one difficulty is that an improvement in one measure, for example, blood pressure, is difficult to compare to an improvement in another measure for a different group of patients. For example, weight loss. We'll stick with those themes. So at NICE, we use QALYs, and they summarise the effects on a person's health in one measure, and that makes it possible to compare across different diseases. Surrogate outcomes alone, such as blood pressure, don't provide enough information to decide whether or not something is worthwhile doing, given the fixed budget the NHS has. However, some surrogate outcomes, such as return to work or reduced hospital length of stay or number of cases detected, can be really useful and important to inform economic work, especially where published evidence isn't available. And one of the things we're doing is looking more at the use of real-world data. to help us to look at that sort of measure as well. So what is a QALY? Well, a QALY is a unit that takes into account both quantity and health-related quality of life. And it turns it into a single measure of health gain. And this reflects the value that living longer on its own is an insufficient measure of success, and that the quality of life also needs to be considered. For example, hip replacement surgery might not directly increase longevity, but it will give a better quality of life. So the QALY is the common currency that we use. They can be assessed using quality of life, is assessed using a questionnaire, often something like the EQ5D. And we use it so that we can compare quality of life and length of life across different diseases and different interventions. So it provides that common metric. What costs do we include when we're considering the cost effectiveness? Well, typically the cost should be all of the ones that would be imposed on the healthcare budget. So things like drugs or the intervention cost, hospital stays, primary care use, adverse events and so on. We don't typically include wider societal costs, for example, productivity. Okay, and then the final technical bit is what is an ICER. So we know that a QALY considers length of life as well as quality of life, but how do we use that in cost effectiveness? Well, we turn it into an ICER, an incremental cost effectiveness ratio. So because the NHS has a fixed budget, any money that is spent on an intervention is then not available to spend on other things. So something which is referred to as an opportunity has to be given up, either for this group of patients or a different group of patients. And ideally, you want to know that any new intervention will offer greater benefit than what you're currently providing. But often, while it's better, it can be more expensive. So we need to decide whether the increased cost is associated with increased effectiveness and whether that's reasonable value for money for the NHS. So the ICER is the ratio of the difference in the mean costs of an intervention compared with the next best alternative. And they're expressed as a cost in pounds per QALY gained. So in this example, the incremental cost is calculated by the difference in costs. So the usual care would have been 8,000 and the new treatment is 28,000. So there's a difference of £20,000. It's then divided by the difference in QALYs. So the original treatment would have provided 1.5 quality adjusted life years. The new treatment will provide 2, so that's an improvement in 0.5 quality adjusted life years. So you divide the difference in cost by the difference in QALYs. Oops, sorry, gone too fast. And you'll see in the bottom right hand corner, I thought I'd circled that in red, the cost is £40,000. So the ICER is £40,000. This is just a landing page from one of our guidelines. I'm not going to try to say the name of the treatment primarily, so I've got a cold, but we'll refer to it as TA665. And on the left-hand side, there's the menu, and you'll see that there's committee discussion that I've highlighted there. And then within the committee discussion is the cost effectiveness results. And you can access that, and it summarises the data and the discussions and considerations that were made when making a decision about the cost effectiveness of the treatment or the intervention. I've also highlighted just under there, there's a bit called other factors. And this is where any inequalities issues are identified as well. So in this case, there was an issue around accessibility of one of the tests, and that healthcare practitioners will need to consider physical, psychological and sensory or learning disabilities when using one of these particular tests. So I'm going to pick it up a bit now, so I realise I'm running out of time. But just to say that earlier this year, NICE produced or published its 5-year strategy. And within it, it includes a renewed determination to prioritise our work to reduce health inequalities. And health inequalities is a cross-cutting theme throughout our 4 strategic pillars, which include rapid, robust and responsive technology evaluation, including an extended capacity to include a focus on inequalities. Also dynamic living guideline recommendations, which are to support evidence-based practical improvements to people's lives and to address health inequalities, and also more work to improve uptake of guidance and maximise our impact. I've included a definition of health inequalities. I won't go through it all, but they are systematic, unfair and avoidable differences in health that arise because of where we're born, where we grow, live, work and age. And we're committed to doing more to address health inequalities in the work that we do. So we've literally looked at our whole guidance development process, from research recommendations through to measuring uptake, and we're identifying and prioritising opportunities to do more to embed consideration of health inequalities within our work. We have a number of work streams that I'm overseeing. This one, methods and processes, is actually being led by my colleague Leslie Owen, and she is working with the University of York to develop a prototype equity impact calculator to support consideration of the impact of specific technologies or interventions on health inequalities. So to look at how different interventions impact on health opportunity for different population groups. We're also looking at our equality impact assessment process, and as I mentioned earlier, the potential to use more real-world data to inform our approach. So the Health Equity Impact Calculator has been developed by the University of York, and the intention is that it will enable us to produce simple estimates of the general impact on social inequality and health. There's also a checklist in development to help structure committee discussions, really, to help them to think about the different impacts of guidelines on a wide range of audiences. However, I do think the tool could be really useful for commissioners and planners as well, because you can model the impact across different population groups. So the tool calculates the impact across 5 socioeconomic groups using the Index of Multiple Deprivation, the IMD. And I'll just go to the next one. It basically gives you another dimension. So you have the cost effectiveness, the impact on the total population, but you can then model the intervention and the impact, and it considers the uptake and access to interventions for different population groups as well. So you can look at where some groups might have the potential for greater impact. So they have their health might be poorer currently, and the intervention has the potential to improve their health more significantly than other population groups. But that group of people might have poorer access to the service. So, for example, homeless people without a GP might have poorer access to hepatitis C treatment, and yet their potential and their need for treatment is greater. So it really adds that additional dynamic. I have been engaging a lot with people who use NICE guidance and trying to understand what would help them to address health inequalities in their work. And they've been giving us lots of feedback, but any additional feedback would be really welcome. And whilst I'm leading this piece of work at NICE, I am your local face, albeit a red-nosed one, for the Midlands and East. So really keen to work and engage with you. And to find out what more we can do to support you with addressing health inequalities locally. Thank you very much. I'm going to stop sharing now.
That was wonderful, Deborah. Thank you ever so much for that talk. And again, the bit that, obviously all of it was exciting, Deborah. I'm not suggesting any of it wasn't riveting, but the really exciting bits at the end around the tools to address inequality, because as we know, previously, HTAs often, and drugs and tools are tested on our poorest populations. When they get HTAs and they're launched, they're used by our richest populations because they read about it in the papers and get access. So an idea of being able to do that is super exciting. But of course, one thing that you did use a terrible word today, use the University of York, because as you know, as we now move on to Gwyn Bevan, who is a professor at the London School of Economics, will tell you that they're much better at economics than York. And I'm hoping, Gwyn, that you're ready to share your slides and to talk through allocative efficiency and how that can make a difference to systems like STEM.
Yeah, I'd like to do that, except the host has disabled participant screen sharing. I've got the message. So
yeah, somebody, if some kind person could reconnect Gwyn with his powers to share, so I think that could be.
That'd be really nice.
Yeah, it'd be really nice. We were there before, weren't we, Gwyn?
We were, yeah.
So if Deb O'Callaghan, in fact, or Deb Mabley, if they could make Gwyn.
If in doubt, Gwyn, I have your slides, Gwyn. Okay. Do you want to kind of go through and you just do the virtual nudge somehow, like now, boy, and I'll do it.
Oh, wait a minute, I think I can share now. I think. Yeah, there we are. Ready from the start.
Super. Over to you, Gwyn.
Okay, great. Well, it's a great pleasure to be here. Always fun to be with Andy. I'm going to talk about this approach, which comes out of work at LSE, led by Larry Phillips, and it's about the socio-technical allocation of resource, which we call STAR. And this is work done through through funding by the Health Foundation with this amazing team we had at LSE: Mara Aroldi, Alec Morton, Jennifer Smith. And what we do is to look, as Andy was saying, we're interested in how we can get more value across a care pathway without spending more money, that covers all paths of the care pathway, going from early prevention to various intensive interventions at the end. And the key element in STAR, the social part, is that stakeholders are key. If we're going to move resources around from one part of a care pathway to another, it's vital we involve all the key stakeholders. And there's obviously clinicians and managers, epidemiologists, finance people, and so on. But for us, the most important stakeholder in the room are the patients, because if you want to compare benefits across the care pathway, they're key, and they also enable us to work out what really matters to patients and all agencies involved. And what we find when we do these decision conferences for STAR is that typically pathway are sat in a room at the same time. So this is the social part. The technical part is that to have an informed discussion, we need to identify these key element data on each component of the care pathway. These are numbers who are treated, numbers who benefit, what the costs of treatment are, and what the value is. And the value we estimate, as Deborah described so clearly, is in terms of quality adjusted life years. But all these data, as anyone who works with data knows, is always not as reliable or accurate as we'd like. Even costs aren't clear. Working out what QALYs are is always contentious. So we've developed models that translate these data into information and also enable us to do sensitivity analysis around whether the outcomes we get are robust to changes in the data. And what we've done here, I mean, the way I describe this is this Health Foundation funded a 10-year project, cost about £1 million, involved a lot of brilliant people working for me, and we see it as applied common sense. So the idea is that people do health economics in the room without realizing they're doing it. And to do that, we have two visual models. And the first visual model is the value for money triangle. And along the horizontal axis, we have costs. And typically in terms of hospitals, as you know, nearly most costs are fixed and don't change with the numbers of patients. Then there's a bit that varies depending on the numbers of cases you treat. And that the combination of fixed cost and variable cost per case and numbers treated give us the total costs. And on the vertical side of the triangle, we have the value, which are the numbers who benefit, who may be different from the numbers treated, particularly with preventive interventions. If you give a preventive intervention to a large number of people, only proportion will benefit. And the total value comes out of the QALY gain per case. And that then gives us the triangle, and the slope of the hypotenuse of the triangle is actually the value for money, and it's not cost per QALY, but QALY per cost. And the great advantage of that is that if you have two different triangles, this is one with very good value for money, because you can see with limited increases in costs, you get huge amounts of value. And if you compare it with this other component, you can see you're spending lots of money and getting very little value. So just looking at these triangles, you can easily see which one gives you good and poor value for money. And the next step is what's, just to impress your friends, is called the efficiency frontier, where you rank the components according to their slope, which is the cost effect of the different interventions. But the key thing that we recognize in the NHS, although we're all desperately short of money, is the scarcest resource that we have is our capacity to effect strategic change. So although if you rank all the triangles in this simple care pathway, the green one is the worst in terms of value for money. You want to target your resources at the one that's consuming most of your resources. So this second visual model enables you to see where you ought to move money from and where you ought to move money to. Now, the problem that we have is that the way the NHS generates data, which we can use for information, is we typically know what the fixed costs are, we know what the variable costs are, we know the numbers treated, we can pretty well estimate the numbers who benefit. But the thing that we're typically missing on a routine basis is what the QALYs are, the benefits we get from an intervention. Now, the issue that you've got, of course, is you've got all these stakeholders in the room together, you've got patients, doctors there, you talk about reallocating resources along the care pathway. And if you sit them down and say, we can tell you what things cost, and you can tell you what the numbers are, but I'm afraid we don't know what the benefits are, they'll think you're joking. You know, why on earth are you getting us in this room to discuss how we can improve value if we don't know what it is? Now, the issue that we get, this is what is known in the trade as horse and rabbit stew. The recipe for horse and rabbit stew is you take one horse and one rabbit. And the problem we often have in economic analysis is we have this uncomfortable feeling that we've got really good data on the small bit of the problem. On the horse, we don't have very good data at all. And lots of people think that the problem with, that we can't do this kind of value for money analysis because what we have from randomized controlled trials only applies to a small part of elements of the care pathway. And if we don't have anything from randomized controlled trial, we know nothing about it. Now, that is not true, of course. And indeed, RCTs are not the gold standard because the obvious problem is they're limited in scope across the care pathway. Often, what goes on in practice produces different benefits from what's reported in randomized controlled trials. Another reservation about it is often, and Deborah referred to this in her talk, is that what patients value is different from what's captured in terms of clinical outcomes reported in randomized controlled trials. And what we find is you can actually work with people, patients and doctors, and they can work out what the benefits are. And so the randomized, so both of these are actually, neither of them is perfect, but certainly much better than nothing. And then, as Deborah described, although she used the scale from 0 to 1 and 0 to 100, what we find is that patients are really good at doing this work and working out what QALYs are. So, for example, I was working with a group who had bipolar disorder, and in the discussion, they said, well, actually, if you're not treated, people with bipolar disorder do commit suicide. So they reckon that untreated bipolar disorder is equivalent to 0. And if you're under drug treatment, it moves you away from that. But it'd be up to something like 40. But it's not, you're not in a great state. But this was in Birmingham, where they had really good psychological and psychiatric support. And they said what that does is to make us feel in control of our lives. And so this moves our quality of life up to 80. And interestingly, I had a similar discussion on back pain, as to if you've got back pain and drugs just enable you to relieve the pain, you don't feel that great. But if you've got treatment that enables you to feel that you're in control, you move up to being close to being perfect quality of life. This is what Mara Aroldi did in Sheffield in the treatment of breast cancer. This is breast cancer with a poor prognosis. And this shows you how you work out the QALY, which are these trajectories of quality of life over time. So this green dotted line here is without treatment, which shows falls in quality of life and people dying in about 18 months. And then if you get treatment, of course, the treatment itself is really unpleasant, quality of life falls, but then you get better, you go on for a bit, and then it falls a bit and so on. And what we found is that working with patients and doctors for different components in the care pathway not enables you to work out what the QALY is. And this is the difference in the area under both these different things. If you take the difference of those two, that will give you what the QALY score is. But these discussions not only gives you numbers you can use, but it will enable you to understand what's going on in the different care pathway. Now, this is work we did with Richard Glover in NETS in Hartlepool across chronic obstructive pulmonary disease. And this is a typical efficiency frontier we get whenever we look at care pathways. And basically, this is money going along this axis and value going up this axis. And what this is telling you is that most of the money, that's this bit here, is producing very little benefit for chronic obstructive pulmonary disease. The early intervention, which is smoking cessation, is hugely beneficial to preventive intervention. I was involved in this group here with this young, brilliant woman hospital physician talking about people with COPD being in acute admission. They really shouldn't be there. This is the wrong place for them to be, and they get very little benefit. And this is steroidal inhalers. And the nurse who is expert in this said the real problem is a lot of people using these inhalers don't use them very well. So they're very expensive, but they don't produce much benefit. And the other thing that's really interesting is the one intervention that's supposed to be directed at COPD is pulmonary rehabilitation. And people were stunned to find what a minute contribution that makes. This is 3 is the flu jab, which is taken to be enormously effective. And 2 was people were estimated what cognitive behavioral therapy might do. So the point about this analysis is it gives you, I think, a picture's worth 1,000 words. I mean, a fantastic overview as to where you're getting your benefits and where the money's going and where it's a lot of spend for very little benefit. The point I would make, and this is Clement Attlee, a man of few words, the Labour Prime Minister, the post-war Labour government, and he was asked, what's it like to be 80? To which he replied, better than the alternative. And I do recognise that the approach that we've developed is inevitably approximate because it relies on stakeholders working out QALYs, but I do believe it's better than the alternative. So that's the end of my talk, Andy.
Thank you ever so much, Gwyn, and Horse and Rabbit Soup has stayed with me for years. So thank you for sharing that again. And so we will now pass on to Peter Spilsbury. But again, just to remind everyone to leave your questions in the chat. And so thank you so much for the questions we've had. And we're answering some of them as we go. But of course, if you've got any additional questions, please feel free to ask them. We will now pass over to Peter Spilsbury, who is having some technical difficulties. So fingers crossed he will be okay. And once Gwyn has stopped sharing his screen.
Sorry, can I stop sharing? Oh, sorry. There we are.
So hopefully you can see my screen. Is that okay?
That's good, Andy. Thank you.
Fantastic. Over to you.
And can you hear me okay? Yeah.
Oh,
Oh.
yeah, 2 seconds.
Yeah, sorry, my internet's crashed twice in the last few minutes. So I'm hoping if it happens again, I don't know quite what to do. But anyway, let's hope it works. So hi everybody. I'm Peter Spilsbury, Director of the Strategy Unit. In 1983, I think I was an economist, but I've got better. Anyway, I'm going to share one example from 2012. When the Birmingham Solihull PCT cluster, I don't know if anyone remembers the PCT clusters, another variant of NHS reorganisation, but the Birmingham Solihull PCT cluster managed to agree how it was going to roll out the RAID service, the Rapid Assessment Interface and Discharge Service, which at that time was a brand new model. It had just been developed and tested at City Hospital. It hadn't yet reached the point of becoming part of national guidance and so on. So it was quite a novel thing. And oh no, stay back with the previous one, Andy. Yeah. So in showing you this example, I'm not claiming it's perfect by any means, but what I'm trying to illustrate is that a bit like some of the things we've seen before, that sometimes when you're trying to make complex decisions, it's quite useful to develop a method and try and apply the method. And in this instance, I think the partners to the decision that they made, which was to roll the service out and sustain it, they adopted a method which I've now discovered is called the Ulysses Pact. So they agreed in advance a certain set of criteria that if they were achieved would cause them to take a certain decision and to stick to it, and they underpin that Ulysses Pact with analytical method. So if you go to the next one, Andy. So just a caveat. So this is a real example. This decision was made and the service was rolled out, but the slides I'm showing you are extracts from various reports produced over the period when this work was done. And I'm sharing them just to illustrate the method. So if you try and follow the numbers through across the slides, you'll be on a hiding to nothing, because they're taken from different reports at different times. And so the purpose of this isn't for you to follow the calculation, it's for you to think about the method and the implication. But believe me, when we did this at the time, there was a huge amount of scrutiny applied to the method and the workings, and there was full internal reconciliation throughout the process.
I think
that's it.
Oh, Peter, we lost you for 10 seconds. So
it keeps telling me sorry, I just keep getting things flashing up saying my internet connection's unstable. Sorry, I can't do anything about it. So just a fundamental principle of system science. If the whole system is optimized, the parts won't be. And if you optimize the parts, the whole won't be optimized. That is a fundamental principle of system science. And in a way, it applied in this situation because in order to get the benefit, which they ended up calculating was possible across the system, the Birmingham Solihull system, it required an action to be taken by the constituents that for them will have felt suboptimal, because it meant they had to make a financial contribution. So if you kind of have that in the background, Deming's basic principles of system science. So can you go to the next one, Andy? So essentially the problem that was being addressed, and when I talk to people, they tell me this is kind of like the #1 decision challenge that ICSs face, which is when there are a set of costs and a set of benefits, and the benefits in this instance outweigh the costs, but they're distributed differentially and they don't align. So the costs fall to one part of the system, the benefits fall to another part of the system, and that becomes extremely complicated to work through. So that was the challenge in this instance. So if you go to the next one. So in 2012, we knew some things. We knew what the model was because it had been tested out at City Hospital. It was well developed, well described. And also critically, we knew that based on a robust external evaluation, that it had demonstrated a very positive return on investment. 3 to 1 is kind of pretty spectacular in health service terms. So if you go to the next slide, and yes, the questions that then arose were, can this level of benefit be replicated across the wider system if the service is rolled out? If it can be, and we can demonstrate that, then how do we then make a decision about how to sustain the service in funding terms, given that the estimated cost was of the order of £3.5 to £4 million? And do we try and do that through a traditional approach where we do the business case and we go through endless iterations of the bureaucracy, or do we do something different? And in this instance, they decided to do something different. So if we go to the next one. So if I'll talk through some bits of this just for a few minutes, but essentially there was an initial stage to model the potential impact across the system and the uncertainties around that, and to use that as a basis for agreeing a threshold, a return on investment threshold. There was then a testing period in order to establish whether that threshold had been achieved or not. And I'll talk about that in a second. That then led to a stop-go decision based on that Ulysses Pact test that I described earlier, stop-go. Having passed the stop-go, the distribution of the benefits across the parties was measured. The costs of the service were described and were apportioned in relation to those benefits, and the system then formalised its decision to proceed. And then ideally there's then the implement to learn cycle, though because of course PCT clusters were reorganised, I think that bit wasn't done. It's a common casualty of NHS reorganisation is the learning cycle bit. But anyway, so just to work our way through some of those things, if you go to the next slide, Andy. So the evaluation was done using robust methods. So it was a retrospective matched cohort study using synthetic controls that were derived from national data. So every patient experiencing RAID was matched against a synthetic control drawn from national data. And it focused on the A&E setting and the inpatient ward setting, and it focused on a number of different intervention groups described there. And just incidentally, for those who are interested, the Midlands Decision Support Network has run and will rerun a training programme on quasi-experimental methods for analysts who are interested to know how to do this synthetic control type of assessment. So if you go to the next slide. The evaluation timeline has to be realistic. It takes time for innovations to show effect. And in this particular instance of RAID, a key mechanism was the provision of training and support to staff in the acute sector from mental health colleagues. And it was recognised and built into the design stage model that I mentioned at the start, that was something that would ramp up over time. So if we didn't allow enough time in the evaluation for that effect to come through, we would under-record it. So a critical part was agreeing a realistic timeline against which the evaluation would take place and the determinant of whether the threshold had been passed. Go to the next one. Another aspect of this type of approach was that there are a host of potential benefits and disbenefits arising from an intervention like this. And it was really important for this method to adopt the discipline of focusing in on a small number, the ones that typically from our point of view drove the economic equation, and having chosen them, to stick to them and to not allow deflection from those. So if you go to the next slide, and we agreed a set of primary outcomes and secondary outcomes in each of these settings that were the ones that we would focus on for the purpose of this evaluation and for, if it worked, for the distribution of the costs in proportion to benefits. So go to the next one. So having run the test, and the test, just to make, sorry, I didn't explain it. The test was rolling the entire service out across Birmingham Solihull. So that's what we did. We supported the Mental Health Trust to implement it in all the acute sites across the city. The test was to decide whether we carried it on and who would pay for that. So during the test period against the synthetic match controls I mentioned, the results aren't unidirectional, but the result for the primary measure, admission from A&E, was distinctly positive with as shown on there. And if you go to the next one, same for inpatients, not unidirectional, but definitely strong positive for the primary driver of average length of stay. So having worked through all that and having got to the point in the evaluation where we were able to say that we can make a reasonable assessment of this rollout, this pilot at scale, we were then able to go through the impact that had in terms of savings, commissioner spend, income effects for providers, because of course at that time it was right in the heart of the commissioner provider split and tariff type payments and so on. And we were able to work that through and work it through at full cost and at marginal cost. And we were able to demonstrate, using a method that had been agreed in advance in detail, that it had passed the return on investment threshold. And therefore, the only remaining question was how do we distribute the costs of sustaining it? So if you then go to the next one. So we went through a process of then allocating the total cost of the service, which was about 4.3 million, across all the, firstly between commissioners and providers based on the kind of analysis I've just shown you, and then distributed that amongst the parties based on their actual experience of the benefits during that period. And you'll note a decision was taken right at the outset in this instance to exclude the two local authorities from that. It was agreed by all the parties that the local authorities couldn't bear any additional costs, so their contribution was fixed at the level it was at the outset. So the additional costs of rollout were distributed amongst the parties in the way that's described there. And you will see the end result of this was a very substantial development in a mental health trust, was funded overwhelmingly by really substantial financial contributions from the, at that time, 3 acute trusts in Birmingham. So, go to the next one, Andy. So in terms of how this ran, so to make this work, there are a number of things, I think, that allowed it to happen. The first was that the system did agree at the beginning that it wanted to try and find a way to make the right decision about this service. And a very powerful part of that was the provision of a large amount of qualitative information, particularly feedback from staff working in A&Es, for example, where the initial pilot had taken place, on their perceptions of the impact it had had on flow in their department, on quality, etc., etc. So there was a very strong clinical case coming from the front line to say, there's something important here. We need to find a way to make a decision that doesn't sink without trace in our usual bureaucratic processes. The second, which was kind of fortuitous, was there was a willingness to put a significant sum of non-recurrent money on the line to support an at-scale pilot. So, and there was an availability of that money, but that was there, and to allow it to run for an appropriate amount of time based on the theory of change, to have a realistic opportunity to develop, to demonstrate impact. But I should stress, we agreed at the outset, if it didn't pass the test, the service was going to be switched off. And the way the service was set up during the pilot stage involved temporary employment arrangements and so on, designed such that if we switched it off, we agreed a time limit. So we agreed if it's going to be switched off, the Mental Health Trust would have funding for a certain number of months, but at the end of that, the service would be switched off. So it was a real test. It could have gone either way. The next one was this very clear and very detailed, sorry, go back to the slide, yeah. Very detailed discussion with all the parties on how this could play out at the beginning, so that people entered into this with their eyes wide open. And this very important upfront agreement. And the agreement on the method, so Stephen Wyatt, who led this at the time, he's now the chief analyst for this Midlands Decision Support Network. He took the finance directors of every party through a detailed agreement of all aspects of the method. And for those who are interested, that went right down to agreeing the individual components of the matching of for the matching element. So everybody was completely clear and had agreed the method before the method was applied. And that was really important. Open book accounting on the costs from the Mental Health Trust in the way I've described. Focus and consistency in terms of the outcomes. And everybody signing up to this Ulysses Pact at the beginning, quite publicly, was an important part of how this worked. So last slide. The Midlands Decision Support Network, which some of you on the call, your systems are part of. So all the ICSs in the Midlands. Our ambition across this network is to grow a community of decision makers and analysts that can identify the potential of applying these sorts of methods. This is just one example, but methods that are designed to draw on analysis and take people through some degree of structured decision-making process to get through complexity. So a community of people who can identify the potential for that, who know enough so they can design them into their decision-making processes, that they have within their ICS the technical skills, particularly in their analyst community, to adapt and deploy these methods, and that they can share their learning as they go in doing it. And we've got a number of elements built into our education programs already, as mentioned on the slide. Technical support for analysts around multi-criteria decision analysis, around quasi-experimental methods, and so on. And also we're just kicking off a series of programs for our decision makers on decision quality and critical thinking, which again is about setting the context within which decision makers can think about these types of approaches. So thank you for that, Andy. I hope it didn't break out too many times.
No, Peter, for me, it worked really, really well, and I could hear you for most of that. So, and again, I hope that this is true for everybody else. As you know, we're just about to move on to the panel, so I'd love to have Gwyn, Peter, and Deborah have their cameras on and ready. And of course, we're very lucky to be joined by our guest panelist, Dr. Wayne Smith. It's very rare to say this without being mean, but he is as gorgeous as he is intelligent. It's Wayne Smith. So Wayne, if you turn your camera on, that would be great, and you can join the panel. And we will talk about some of the questions. So for those of you who have questions, please add them to the chat, or flag that you would like to speak, and we can you can turn your mic on. Whilst we're just waiting for any additional questions to come in, I just want to point out that we have all of the links and everything that we've talked about today are available in the chat. They're also available through Twitter and through the Decision Support Network. And one final thing to mention before the panel is we're working right now with the HFMA around this tricky question of allocative efficiency and how systems can actually take this insight into action. And I think that what we've seen today from Deb, Peter, and Gwyn has been a real eye-opener that there are tools out there that can help. So we're hoping to be working with 11 ICSs with HFMA and NHS England on a proposal on running a series of allocative efficiency projects. So just to say that Duncan Orm at Knott and Sue Rollinson in the Midlands, again, helping support the proposal that we're pushing through, but we're hoping to engage all of the Decision Support Network as part of this. So again, we're really keen to have people who are interested in this work to get involved as part of the DSU. Right, I have 2 big questions to start, and I mentioned them at the beginning. And so if I go to you first, Deb, and then I'll go to Gwyn, Peter, and then Wayne. How can we use this idea of looking at value to better address inequalities? Because one of the big burning agendas, again, you mentioned it lots in your talk, Deborah, but a chance for you to revisit and highlight, and then we'll pass to the others.
Thanks, Andy. Well, we've looked across our whole pathway to see where we can support action on inequalities. And there's actually opportunities from thinking about the research that is funded and the research that people undertake, through to the questions that we ask when we develop guidance, ensuring that we're asking the right questions for different groups, looking at the right type of evidence and different sorts of evidence. And I talked about real world data or routinely collected data, not relying solely on published randomized controlled trials and meta-analyses and so on. But I think at implementation stage, there's a huge opportunity to target interventions where they will have the highest impact, or understand where there are barriers to access to interventions or things affecting uptake. And there's a staircase, isn't there, of inequalities. So it considers the different types of, or the different stages at which inequalities occur. So people have or experience inequalities because of where they live, or because of access, because of uptake. They might have different needs because of risk factors that they're exposed to. There might be different health effects because of perhaps lack of understanding about how to follow a treatment pathway, or there's a reference to inhaler use. You know, if people don't understand, if they're not engaged, if we don't understand health literacy issues and support people in shared decision making, then their treatment isn't optimized. There's people lost to follow up, you know, think about access to hospitals and transport and things like that. So there's lots of opportunities to understand where inequalities arise, and it does rely on measurement and data and talking to people and engaging with people to understand where inequalities are arising, and then to take actions to address them. So yes, we do as much as we can at NICE, and we're looking to see where we can do more, but I also think implementation is key, and that's where the sorts of tools that have been spoken about this morning come in, helping people to think qualitatively and quantitatively where there are inequalities, where there's variation, and how can we address them.
Thank you ever so much, Deb. Thanks for that. Over to you, Gwyn.
Well, I suppose that this raises it seems to me like what it does is to spell out the difference, and Deborah mentioned this, between its cost effectiveness and effectiveness. There's other work I've been doing looking at the National Diabetes Prevention Programme, and if you use cost effectiveness, to make it very simple, you know, if 1% of people who are enrolled in this program, which costs about £200, so you go on a 9-month course and coached every 2 weeks in better lifestyle and, you know, eating better, losing weight, and taking exercise. If you can stop 1% becoming diabetic, that's cost effective. But actually, if you really want to tackle inequalities in health and people becoming obese, type 2 diabetes, you have to go into the structural determinants. And so it needs a different focus. And the trouble with cost effectiveness is the marginal gain, as Deborah explained it's the marginal gain versus marginal costs. But if you really want to tackle health inequality, you're going to get into these structural questions.
Thank you ever so much, Gwyn. Peter.
Well, I think all these types of methods have all got their roots into tackling health inequalities. I mean, it's always important to choose method to fit the question. But a couple of thoughts really in my mind. So one is I think probably the most important discussion to be had at the beginning around inequalities in systems is how much inequality are we prepared to tolerate? And are we more concerned about the scale of it? So are we more bothered if there's 1 million people who are affected by a small degree of inequality, or are we more bothered by instances where it affects a small number of people, but the degree of inequality is very high? And until we've worked out how important, it sounds a ridiculous question, because I'm sure everyone on the call say, well, of course it's important, but what does that mean? So essentially debating our values about what kind of weights we're going to put on these is a fundamental underpinning for whichever method we employ. And if you think about the slide Deborah put up, the quadrant that says low cost effectiveness but high impact on inequalities, what's our stance going to be in relation to that? Are we prepared to invest in things that have poor cost effectiveness but have strong impact on inequalities? So thinking about the ethical and philosophical underpinnings strikes me as the most important. But having done that, all of these methods give a really good way to to throw light and to take people through a complex process. But you could go through all the processes in the world, and if you haven't thought about the underpinning values and how legitimate those are, how do you get legitimacy for those from your population, for example? I think you're going to keep getting stuck. We are going to keep getting stuck.
Thank you. I do see your hand up, Deborah, but can we first go to Wayne Smith? Wayne, your PhD was in creating these, kind of novel methods to look at the qualitative input to these kind of models, things. And so I'd love to have your view of how these, technical and allocative efficiency can help address inequalities. What do you think, Wayne?
I think ultimately what we're looking at here is how do we improve methods for complex decision making. And of course, Deborah, Gwyn and Peter talked about some of those methods. Deborah talked about the health inequalities tool and Gwyn about STAR. And so these are sort of important models and tools that we need to help address these issues. One also important aspect is using the sort of real world data, because that really helps us to identify where those health inequalities might lie in the population. And when we start looking at technologies that are put into the system to help support treatment across different clinical areas, we'd want to understand where those technologies might help address those sort of health inequalities. One other method that I think kind of sits with more so with STAR is MCDA, that's multi-criteria decision analysis. And what the heart of that method is to kind of identify additional criteria or attributes that will be useful in helping to inform those decisions about new technologies and treatments. And of course, if you think about that, one of the criteria that we're talking about here is that issue of health inequalities. Also, Gwyn mentioned around using these sort of getting more input from stakeholders as well in making those decisions, and within multi-criteria decision analysis, we really are dependent on various stakeholders and trying to understand what attributes or criteria are important for those individual stakeholders. So that's definitely worth thinking about.
Thank you ever so much, Wayne. Deborah, you had your hand up. Is there anything you would like to add?
It was just really in response to Peter's points about how important are health inequalities, and one of the features of the tool that we're working on with another university is, other than LSE, is that you can set the tolerance for health inequalities. And it is really difficult, isn't it? And when you asked if I could talk about the tool, the honest truth is we're really testing it and really trying to understand how it can be used. And one of the things that we're doing at the moment is going through a series of deliberative public engagement to understand the public's views on health inequalities and whether some inequalities are weighted differently to others, and trying to do it in a neutral way that removes the element of judgment, because some people feel that if you've brought the inequality on yourself, then they have a lower tolerance for it. And, you know, it's very complex, but yeah, fascinating area and something that we're, you know, really keen to all work together on.
Thank you, Deb. And in fact, that touches on 2 points, or 2 of the questions that have been raised. One from Shirley about public engagement, and the other one about Louise about how we balance off items that may be less cost effective than the current and how we address inequalities. But Gwyn, Peter, I'd love to just pop to you quickly and just talk about how do you bring the public along with you on this? It's so important. So Gwyn, I know you may have mentioned in your talk, but Shirley may have missed it, but how do you get the public involved as part of STAR? And Peter, how did you keep them involved as part of your project?
Peter, do you want to talk? Because I can't say a great deal on this. Do you want to?
Okay. Well, in that particular example, Andy, the RAID one, I don't think there was a major emphasis on public engagement. There was a lot of emphasis on drawing on the experience of people who'd used the service as and the staff who were providing it and the staff who were impacted by it in terms of making the case for why adopting that method should be done. I mean, I guess my general observation, I mean, there's a cost in having big conversations, but there's a cost in not having them. And quite frankly, when we're spending billions of pounds on behalf of people who've effectively pooled their money in a collective endeavour to try to improve health for the population, I think we should be much more willing to take the cost of having those conversations. But I'm kind of increasingly persuaded it needs to happen in a number of different ways. But the way that we undercook in the NHS, in my view, is the kind of more systematic social research side of it and the use of structured deliberative processes. If you look at some examples that have taken place in this country and internationally, where a serious attempt to support a proper deliberative process, where members of the public and staff and others come together and go through an extended period of discussion where they can draw on evidence and debate things through in order to reach a considered consensus position. It seems to me that we need to spend more time and resource on supporting those types of processes. Because
I mean, I think the thing is it's quite difficult to get the patients involved. And basically the reason why I didn't think I could say much about this is we work with stakeholders, you know, and people in the NHS, and they get the patients involved. But the thing I remember so vividly from the work we did in Sheffield, this is work that Mara Aroldi did on patients with eating disorders. This was again back in olden days when we had primary care trusts, and the primary care trust was really, you know, reluctant to get patients involved in this. They thought it'd be much better if the NHS decided what the good solution would be, and you then consult with the public afterwards. And we were not at all keen on this. And we insisted that we got the patients involved. And in the work on eating disorders, there was a woman who had severe anorexia, and there was a mother whose daughter had died from anorexia. We made this impassioned speech at one point in the conference saying how important it was to do something about this. And when Mara was working out the efficiency frontier, and all the data put in, it shows that there's this out of area treatment for people who are acutely ill from anorexia, and if they don't get this 24/7 care, they'll die. And that turned out to account for something like 80% of the resources and 2% of the total benefits. So she thought this isn't going to play well with these two people, one of whom's been through this, the other whose daughter's through that. And what it showed in the efficiency frontier is that it looked like early intervention done in some university practices with women in counselling was a phenomenally cost-effective thing to do, enormously beneficial for low cost. And both these stakeholders said, you've got to move money out of this intensive unit into this early intervention. The mother said, if you did this, my daughter might still be alive today. And the woman with severe anorexia said, you know, you don't want people to end up like me. You've got to get these early interventions in place. And I think it's really interesting here about how getting patients involved, you know, just brings it through. And Jennifer Smith, who was Director of Public Health in the Isle of Wight Primary Care Trust, you know, for her experience of involving us with the stakeholders, she says it's very low risk and hugely beneficial. And if you really want to capture what benefits are to patients, get them involved. It's critical. I mean, it's quite difficult to do. That's why, but it's well worthwhile.
And I think that's it. And I know for the work that we did with STAR in Northwest London, we used to have patients and the public sitting in on the kind of stakeholder workshops as well, to get their views. But I think that we can all agree that getting the public involved is key. And even though, as Peter mentioned, it may be somewhat expensive and time consuming, but it's worth it, not only to get their real understanding, but it'll be worth it in the long run. Wayne, what do you think about public involvement?
Yes, you're right, Andy. We do try to have patient and public involvement leads in all of our research and studies, but also when we're applying to use our real-world data, especially through those data research access groups, we would usually have a layperson on that panel. So that's a sort of direct way of getting the public involved in research and making them aware of the types of studies that are happening across the NHS. Another way would be to to have GP practices sort of make patients aware of studies and pilots that are running across the system as well. Thank you
ever so much, Wayne. Another one of the questions we've been asked is there structured methodology for patient input? And I know we've kind of touched on it in here, but do you guys know of any kind of very clear structured methodology that's been created to get patient involvement? I'll start with you, Deborah, and then go to Gwyn, Peter, and Wayne.
I've just posted in the chat a link to our public involvement pages. I have a colleague, Mark Rathbun, and he and I did a session recently on community engagement to address health inequalities. And our programme does have an approach. They have a model that they use, including how to consider the groups that are likely to be affected, and then use that to influence how you engage with them. So whether it's necessary to engage with an intermediary organisation rather than seek to engage directly. So, for example, we can't engage with children. We're not allowed to in our guidance, so we have to engage with intermediary organisations. But yes, he'd be very happy to share it with you. And I've shared a link to the page on our website, and just let me know if anybody would like a separate session. I'm sure Peter will help me out somehow, but we could do something there if that's of interest.
That's fantastic. Gwyn, any structured methodology that you're aware of for patient input?
No, I suppose the thing is, it may seem slightly odd for someone in an ivory tower, but the thing is, I think it's my feeling is that doing these quite approximate calculations that we do with STAR. I mean, I do see patient involvement as critical, but I think my concern in all this stuff, and often when we present this work, is academic health economists get deeply uneasy because there's not stuff from randomized controlled trials going into it, and how reliable is this data? But whenever we do this with sensitivity analyses, because you're moving from things which are consuming lots of resources, little benefit, to things that are the other way around, it's well worth doing. So my I mean, as I say, it may seem slightly odd for an academic, but I really do think just using approximate approaches, without being too troubled about academic rigor, you know, there's enormous scope for the NHS to get more value without spending more.
If only you took that view when you were marking my homework, Gwyn. Peter, over to you. Peter, do you know of any say any kind of clear methodologies that we could share, or any views, you know, for patient input on this? Again, it may not be your bag on this, but anything that you're aware of?
Was anything technical that ceases to be my bag? But actually, well, I think that I do know of one actually, because we've been involved in a project recently that's used it, which, well, two actually, which is this potential use of conjoint analysis, which is a process by which you you elicit the preferences of a group through providing them with a whole host of different scenarios which they score. So in the instance we did it, we were using it to try and understand how different levels of COVID might affect people's sense of risk about proceeding with an elective procedure. But I'm sure you could use that kind of method in other contexts. And you can support that method with another approach, which is called revealed preference analysis, where you try to look at the historical data to see whether what people report as being their preferences seems to be borne out by actual behaviour. So it's very, I mean, I'm sure they're only going to be applicable in certain circumstances, but they're perhaps examples of ways you can start to treat data that comes from the public and from staff with the same degree of rigour and methodological sort of robustness as we do with other data, and that might be appropriate in some situations, not in others. But anyway, they've been my.
No, thank you, Peter. You mentioned conjoint analysis and kind of discrete choice analysis, which of course then will get Wayne very, very excited. So Wayne, was this a question planted by you? Over to you.
Hold on one sec. Sorry, I hope you're not testing me on the technicalities of those. But yeah, so as Peter said, those are sort of like preference elicitation methods, and they're all various types of methods that fall under that category. You mentioned conjoint analysis, and then there's discrete choice experiments and all sorts of interesting ways of identifying patient preferences or pubs. On a more kind of general perspective, I think you've all touched on how you involve or engage the public. One of those would be through data access or through patient and public involvement leads, also including in the public, or trying to encourage the public and patients to take part in pilots and research. And then, as Peter said, more specifically around the research and how you kind of tease out those preferences would be to apply those specific methods. That also falls under things like multi-criteria decision analysis. As you can tell, I'm really interested in that. But how you then tease out the preferences of those involved in those decisions. You know, you can use survey to a bit more sort of analytic approaches, which combine qualitative as well as quantitative aspects, and those are the ones that Peter talked about.
Thank you, Wayne. I'm going to come to you all again for one final sentence from you both. We've talked today about how value is and different approaches to looking at values for systems. ICSs will have to deal with these wider determinants. They have to go beyond healthcare, because as we know, 20% of health outcomes comes from healthcare input. The real challenge is, how do they create the case for change, and how do they understand the value and know best where to move that value about? Deborah, Gwyn, Peter and Wayne have shared their thoughts about this today, but I'd really love to know from each of you a sentence, a key bit around the insight that we've learned, or the insight we can get from understanding value. How can that help ICSs, or how can we turn that into action as part of this festival of Insight 2021? So from what we've heard today, what's your key tip for taking value into action? Over to you, Deb.
I think that's really mean. You could have said that beforehand. I think, bearing in mind my current psychological state, I think be curious and talk. We need to understand, we need to use different types of data and intelligence, don't we? The traditional sources aren't telling us everything we need, so we need to do the community engagement. We need to ask questions internally, you know, of our colleagues and ourselves and our ethos and our way of working. You know, how important is addressing health inequalities, and you know, what are we going to do about it? So I think mine would be curious, and you know, let's work together on it.
Thank you ever so much, Deb. Gwyn, your one tip to take on this insight into action. How do we do it?
I think it's like Peter's story of, sorry, not story, undervaluing all this technical work that went into it. It's the it's actually the social part and getting people prepared to move money around. So the issue that we face typically, I mean, I don't, frankly, I'm not told about all the technical qualifications that go into all this. It's just being able to get the acute sector to agree to move money out into the community sector. And no matter how sophisticated our tools are, and what else we put in it, unless you've got the willingness to do that, it's all a waste of time.
Thank you, that's brilliant. I'm Gwyn. Peter.
The work we're doing on decision quality now, as we're in association with the Midlands Decision Support Network, kind of one of the sort of platform things for that is this little saying that the most important decision you make is how you're going to make the decision, and I think that there's a whole load of stuff about creating the kind of collaborative culture in which this happens, but the decisions in a complex system are complicated, and thinking about methods and thinking about credible timelines by which decisions might get made, and thinking about how they get made in the context of a learning system, you know, almost without question, anything we do will have unintended consequences. If we're not prepared to kind of approach it in that way, I think we'll keep struggling to bring this to the fore.
Fantastic. And Wayne.
I think ultimately it's to consider criteria besides cost effectiveness analysis or effectiveness analysis, and consideration all of your various stakeholders, how they can help inform these complex decisions that we're making.
Thank you ever so much, Wayne. So thank you, Deborah, Gwyn, Peter, and Wayne. It's been fabulous to have you here. Thank you, Insights, for letting us have this session. And please stick around for the remainder of the day. As you know, Rachel just shared some of the agenda there. There's some great stuff for you to see, including an amazing session called Share Your Awesomeness, which of course I must have to attend because that just sounds brilliant. Later today. If any of you are interested in attending or getting involved in the allocative efficiency work we plan to do with the DAS, Decision Support Network, and HFMA and NHS England, please let us know and contact us through the network. And of course, remember two amazing other panels, looking at inequalities, which is Tuesday, where we have Sir Michael Marmot coming along with some other distinguished speakers. But of course, I think that Friday, God knows how they've done it, but they've managed to get Jennifer Dixon, Nigel Edwards, and Richard Murray all in one room at one time. God knows how they've done that, but Peter must have called in a huge favor. But it's a really interesting session this Friday. So thank you all the very best, and have an exciting Monday. Cheerio.
Thank you.
Thank you.
Thanks.